You're watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, an important topic, probably the most important topic we've ever covered, new treatment options for people that have been diagnosed with cancer. If you or a loved one have been diagnosed with cancer and have not started treatment yet, my advice, stick around for the latest edition of The Wellness Hour.
The Wellness Hour, an in-depth discussion with today's top physicians and medical leaders. And now, your host, Randy Alvarez.
You're watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, new treatment options for people that have been diagnosed with cancer. With us, we have two radiation oncologists, Dr. Ted Masek and Dr. Greenburg. Doctors, welcome to the program.
Thanks for having us.
Now, Dr. Masek, we've had you on the program before, so we'll start with you. And for people that don't know what a radiation oncologist is, tell us.
Radiation oncologist is a doctor who's gone through medical school, internship, and residency, and specialized in treating patients with cancer with radiation. They're one of the three main groups that treat cancer: surgeons, medical oncologists, and radiation oncologists.
Now, Dr. Greenburg, you just left, I guess, Desert Hospital to join the team.
Correct, yeah. I've been in the desert now 15 years, and my partner here, Dr. Masek,
About 18.
about 18 years now.
Now, is it true, by the way? I mean, you're the most experienced radiation oncologist in the desert?
That's
Is that
us.
fair to say?
It's very accurate.
Yep, that's true.
We've, Randy, we've been in friendly competition for the last 15 years.
You two
Yes,
have.
Peter and I.
Okay.
And it's been a great relationship. Every innovation in radiation oncology that has been brought to the desert in the last 15 years has either been done by Peter or I.
Dr. Masek, you were the first in the desert to have that trilogy.
Yes, the trilogy is a machine that allows us to treat cancer with every form of radiation: IMRT, stereotactic radiosurgery of both the brain and the body, and also to do something called respiratory gating.
Okay, now as far as options go, because today's program is about options, somebody's been diagnosed with cancer, where do you stack up as far as the desert with options for patients? I mean, are you
Great
leaders?
options. We're leaders. I mean, one of the nice things about the desert is we've had the ability to provide patients with terrific options for treating their cancer, so they don't have to go other places to get cancer treatment. And one of the nice things now, particularly with what we've got going on, is the latest option we're bringing on is tomotherapy.
Isn't it true, though, that the hospitals have more radiation options for cancer patients than you do?
Actually, we've got
Or it's
more.
not true?
Yeah, Randy, we've got more radiation options than the hospitals have.
Okay.
We've got both the trilogy machine that Ted has already referred to. We've got the respiratory gating, which the hospitals don't have at this point for treating lung cancer patients. Plus, we're putting in tomotherapy, which is the newest option that's going to be available to patients out here in the desert, and that's something the hospitals don't have.
Okay.
And what that means, the respiratory gating and the stereotactic radiosurgery, 6 months ago when I would treat somebody with early stage lung cancer, I might have a 20% chance of controlling that. I've increased that with stereotactic radiosurgery to 85 to 90% chance of controlling those patients, and we can give all the treatment in 3 to 5 fractions now.
So the newest thing then in the treatment of cancer therapy when it comes to radiation is this tomotherapy?
It's a great advance. I mean, it's a type of machine that's designed to put high energy radiation beams into tumors and give very little dose to the surrounding tissues.
Let's begin with early diagnosis. Somebody's been diagnosed with cancer. Who does the diagnosis, and then when do you get the referral?
Generally, the diagnosis is going to be done by a surgeon, although sometimes a breast cancer patient may be diagnosed by a mammographer with a needle biopsy. So the patient's going to come to us either through the surgeon, might come to us from the medical oncologist, a urologist if it's a prostate cancer patient. So those patients come to us already with a known cancer diagnosis.
What kind of cancers are you treating at your center?
Randy, over 50% of the patients that are diagnosed with cancer will get radiation at some point. So we're treating rectal cancers, colon cancers, lung cancers, breast cancers, cancers of the brain.
Prostate cancer as well?
Oh, absolutely, prostate cancer. We do a large volume of prostate cancers.
Okay, so now we're talking about two therapies today. We're talking about this stereotactic radiosurgery and this tomotherapy. Is that correct? Two different machines. They target the tumor, and I guess the goal is to not damage the surrounding tissue.
Exactly. I mean, the goal with all these treatments is where we've gotten so much better than we used to be is two ways. One, we can identify the tumor much better. I mean, we can find the target better than we ever used to be able to do, number one.
Okay.
Number two, we can get the radiation beams into those tumors and skirt around the normal tissues in the body. For instance, if you're going after some tumor in the middle of the abdomen, you've got the kidneys to work with, the liver, you've got the bowels, the stomach, and we could aim radiation beams in multiple different directions to miss the sensitive structures and get to the middle, say, where maybe the pancreas is.
Okay.
And in the past, when we tried to treat those types of tumors, these patients would get quite ill. Now we can sneak the radiation into these areas and do the treatment much more easily.
Are your cure rates better now than they were 10 years ago? Are they that much better?
I think so. The studies have showed there's actually less cancer deaths in the country from people with cancer than before. That's in a population that's growing. So yes, we're doing a much better job in controlling tumors.
Okay, go ahead. And you were going to say.
I was going to say, one good example, Peter, I think, is our head and neck patients. In the old days, when we would treat head and neck cancers, by necessity, we'd have to treat the salivary glands. And that means sometimes those patients couldn't taste their food, they couldn't swallow, their mouth was completely dry. Our patients now with IMRT usually swallow very, very well, have a wet mouth, and are able to function as normal.
Okay, Dr. Greenburg, you told me in the green room, and you said when you were at the hospital, when you were working at the hospital, oftentimes you would have to send these people maybe to Loma Linda, City of Hope, to get things like tomotherapy. Is that right?
Yeah, and what we do now is we're going to have...
did you do that? Did you have to do that?
I mean, Loma Linda University has a proton machine, which we talked about, which is a specialized form of radiation therapy that's only available in a few parts of the country. Now with us having the Trilogy machine, the tomotherapy machine, being able to do stereotactic treatments for brain, for body, we've got the ability to really provide just about every sort of treatment the patients might need at our various centers that are going to be located throughout the desert so that the patients don't have to travel.
So you're 21st century oncology. It's just the both of you. Are there advantages over the hospital? What does the public need to know? I mean, look, you've been diagnosed with cancer. It's a tough time.
Sure.
And I guess, are they going to get better service because you're smaller? Are they going, do they have to wait less?
Actually, the good thing about 21st Century is that it's a large company.
Okay.
And what that allows us to do is allows us to bring the university technology to the community so patients don't have to drive very far. We have over 80 or 90 centers throughout the country. It has an unbelievable infrastructure for physics and help and allows us to bring these high-tech treatments to the patients in the community.
And we've got the ability at our centers to provide very personalized service for patients in a patient-friendly environment, and yet at the same time we're providing this very high-tech university-style technology for patients that previously they'd have to go for tomotherapy, for example, to City of Hope, which is in Duarte, which is a couple hours away from where we practice.
And people are doing that today, though.
People are doing that
in the desert. They don't realize you're there.
And now,
is that going on?
Correct.
That's true. Yeah.
And now we're here. We've got it.
Yeah, I'd also like to mention what type of a company 21st Century is.
Okay.
We believe that everybody, no matter whether they have the financial means, should get treated. So we take all insurances at our department, whether it's Medi-Cal, Medicare, or whatever. Even if you don't have insurance, we will treat you.
Okay, so if somebody, let's say that they've been diagnosed, they're with cancer, they're about to go to the hospital for their radiation oncologist, should they get a second opinion on something like this? I mean, can they? And can they switch? I mean, do they need a referral from their treating physician to see you?
I feel very strongly that there's you can't get too many second opinions. When somebody asks me, should they get a second opinion, I tell them you should get as many opinions until you feel comfortable with your treatment. So if you have been diagnosed with cancer and you're ready to start your fight, give us a call.
Okay, so they could go in and they will see one of you. Now, you're also referred to as the dream team. That means that, and correct me if I'm wrong, they're saying that you have the most experience of any radiation oncologist in the desert. Is that true?
It's true.
Because if it's true, if somebody has cancer, they should request to see the people with the most experience. But don't the machines do all the work? Or is that, does your experience?
Listen, you need both. I mean, the machines are very important.
Okay.
I mean, with radiation oncology, you need two things. You've got to have the best technology. That's very important. But you have to have the experience to have used the technology, to know how to use it, to know what it's capable of, to know when to use which technology, and when it's appropriate for the different types of tumors. And because, as Dr. Masek was saying, we treat tumors in the head and neck, the lung, the stomach, the pancreas, the rectum, the prostate, you've got to be able to decide when you've got a certain type of tumor, which machine is it better for? Because we've got the tomotherapy machine. Which machine do you put the patient on? The Trilogy, the tomotherapy machine? You've got to know what's the right time, and you've got all this technology to use, and you've got to make the right decision right up front.
Let me tell you something about my friend here, Peter.
Okay,
all right?
okay.
Both Peter and I have been doing seed implants for prostate cancer for the last 10 years, all right? When you have prostate cancer and you're going to have seeds placed in there, you want to go to somebody who's doing 5 or 10 a month, not 5 or 10 a year. You know, anybody can miss a nail with a hammer, but the carpenter that does it every day is much less likely to miss it. And Peter has as much experience as anybody in Southern California doing this. So do I.
Then let's begin with the newest, tomotherapy. What type of cancer is it for? Does it work best for? And how does it work?
Well, tomotherapy is like in diagnostic radiology having a CT scanner and an MRI. With Tomo and Trilogy, some cancers can be treated better on tomotherapy, and some cancers can be treated better on the Trilogy system with SRS. Peter, don't you agree that most head and necks should be treated on the tomotherapy?
Oh, absolutely. I mean, with the tomotherapy, you've got the ability to really...
So brain tumors, things like that?
Brain tumors,
those type of cancers?
Brain tumors we might treat on the Trilogy,
okay.
But head and neck cancers such as the base of the tongue, oral tongue,
I see.
tonsil, larynx, we're going to treat those on the tomotherapy machine.
And the reason is that we're able to treat right around the salivary glands and prevent side effects.
So I mean, with technology, I guess this is the best time to ever have cancer in history.
Sure.
I mean, if you could even say that because of the technology. That means there's a lot of promise for people that have had this diagnosis.
Well, and the other thing with this type of technology is not only does it allow us to treat patients with these types of tumors much better than we ever could previously, but in patients who develop another tumor after they've had their first tumor, and that happens with head and neck cancer, probably 15–20% of patients unfortunately develop yet another head and neck cancer. The tomotherapy machine actually allows us to retreat these patients in the future if we need to, and with such incredible precision that we can retreat a new tumor site or a similar tumor site in a patient that's previously gotten radiated, and we can do it with the tomotherapy machine.
And if I can build on this, you know, a lot of patients come to us for cure of cancer, and that's what we want to do. But sometimes the cancer has gone past where we can cure it. But nowadays, instead of writing them off as a death sentence, we're treating them more of a chronic illness. So we might treat a lung tumor, might treat a liver tumor, and these patients can live very high quality of life for many years.
So people that were told they were not, you know, that their cancer was not treatable a few years ago are treatable today?
We don't tell patients that they're not treatable. Everybody with cancer can be treated. And with these new technologies that we're talking about, once again, we can treat
So you can extend their quality of life even if the cancer has really progressed?
In many cases we can. And with these new techniques, we're able to treat multiple areas, limiting the dose to the normal tissue so that we can treat these as chronic illnesses instead of death sentences.
So tomotherapy, I mean, they lay there, it's a beam that targets...
The patient doesn't see anything from the beam perspective. I mean, they're not aware of anything happening with the treatment. The machine itself looks exactly like a CAT scanner. Actually, it looks a little like a CAT scanner on steroids, actually. It's a little bit bigger than a CAT scanner, but not by much. So it looks like this machine that looks like a white donut. Patient lays on a table, and they slowly slide through the donut as they're being treated. And the way the machine actually works, maybe Ted will go into that, is the beam itself is being produced by a small, what we call linear accelerator, that is housed inside this donut. And while the beam is on, it just goes round in a circle, and a little beam of radiation continually is produced that goes around and round to the patient. Tiny little beamlets shoot the tumor as the patient passes through the circle. And within the machine itself...
So the patient's actually moving slightly during the treatment?
Oh, yeah. Almost like on a very slow-moving conveyor belt as they slide through the beam. And there's a very intelligent computer system that knows when to turn the beam on, when to turn the beam off as the patient goes through the system, and it only targets the tumor as the patient passes through in the right location, so that the beam is being shut down and turned off, in a sense, so that the normal tissues are not exposed to the radiation until the patient's at a certain point, both on the table and when the beam is in the right direction to get the tumor to its best advantage, where the beam is sliding in between normal tissues. Beam turns on, hits the tumor, and then if the beam is coming where the beam will come in at a direction where it might pass through a sensitive tissue, then the beam is blocked and it doesn't go through.
Okay. Now, if it's as good as you say it is, why don't the local hospitals in the desert have this machine? I guess this is a tough one to answer, but
I think that...
I mean, is it just a very expensive machine?
It is a very expensive machine, and hospitals have a lot of responsibilities. And a lot of times radiation therapy is not their chief focus, and they can't afford this. At 21st Century, we only do radiation oncology.
Okay.
And so we
That's
focus
all you do.
on that.
And we should mention, I mean, you were, Dr. Masek, I guess you were the medical director over at Eisenhower.
Correct.
You were head of the department for radiation oncology, and you were at Desert Hospital.
Correct.
You were all, and what was your?
I was medical director of the radiation oncology department.
For how many years?
15 years.
Okay. I mean, do you feel like, by the way, that what you have, you know, now that you've teamed up, that what you have is the best center for cancer? Because cancer patients are going to watch this show. Are you convinced that you have the best as far as what to offer in the desert for cancer patients that need radiation?
As far as radiation oncology go, yes, that's the absolute truth.
Okay.
We do it all. We do seed implants of the prostate, we do HDR, we do stereotactic radiosurgery. Patients that come to 21st Century has all the options.
But if somebody is diagnosed, their life is turned upside down, they've been referred to other radiation oncologists. I mean, they can, if they want, get a second opinion. And do you recommend a second opinion? I asked that before, but I can't imagine at this time that they're logically going to think, who are those guys that have the most experience over there?
Listen, we're not...
Can they? I mean, insurance, this is not going to conflict with their insurance?
We don't want to disrupt the normal doctor-patient relationship and the referral patterns. We're not looking to do that. If patients wanted to get a second opinion with us, we're happy to provide it. But obviously, the relationship between a patient and his physician is very important. But
So
we're
with that tomotherapy, okay, so they lay in the machine and they feel nothing at the time. Is that right? Are they awake? Are they asleep?
They're awake, and it's fairly wide open. They don't have a problem with claustrophobia. It's like a large CT scanner. They lay on the table, and they are treated.
How do you set the machine to target the tumor?
Well, Randy, all of our machines have onboard imaging. So when a patient's going to get treated with radiation, they first go through a CT scan, and we identify the tumor and do the planning. Now, with tomotherapy, it's pretty cool the way it's done. They lay on the table, the tomotherapy machine goes around the patient, and we image the tumor, and then we match it to what was planned. We make those adjustments, and then we never miss the tumor.
So how long does the process take, the treatment?
The actual treatments take about 15 or 20 minutes.
Okay,
so it's a daily treatment.
A loved one brings them in.
Right. They're there for 15, 20 minutes. They can pull right up to the front door. We have wheelchairs. We have assistants. It's very easy.
The parking is much better, I guess,
than
it would be at the hospital. Is that right?
It's easy parking.
When I was at the hospital, Peter, that was one of the biggest complaints we had, was parking and patients being able to get in and registration.
I'm not trying to badmouth the hospital, by the way. I mean, great hospitals in the desert. They're known for their hospitals. But so parking, a little bit more individualized service, would you say?
I think that we have very, very good support. Everybody compliments us on our front office staff. The therapists that treat the patients, I'm very proud to say, have the most experience in the Valley also. I have the pick of the litter when it comes to therapists treating the patients.
But you have more than one location.
We do. I mean, we've got the main location in Palm Desert, which has been up and running now for 3 years. The tomotherapy unit is going into Rancho Mirage.
Right, and in Indio, we're putting in another linear accelerated with image guided, and that'll be up and running in November. And there's one more center to serve the patients up in Yucca Valley that have a very hard time driving down that mountain.
And these are going to be your centers. You're going to be running the centers.
And they're going to have state-of-the-art treatment there.
So what's next? I mean, what's your goal? You just want to get the word out for cancer patients that there's a lot of hope?
Well, 21st Century isn't stopping where we're at. We're developing all the time. I think the next big change in radiation is adaptive therapy. And
what does that mean?
Well, what that means is that we actually treat the patient, but while we're treating them, we measure where the radiation goes. And then after we measure it, we make changes based on that. So it'll even be more precise with less side effects.
Real-time changes based on how the tumor is reacting to our treatment.
Right.
So if we're having a successful response during treatment.
And the tumor's smaller?
Tumor's smaller, we shrink down the radiation field.
So you give less radiation.
Right.
So now we don't have those abilities, but that's coming on in the near future.
What is the time frame, by the way? If somebody's been diagnosed with cancer, how soon do they usually get to see you?
Well, I think it all depends whether they get chemotherapy, whether they had to have surgery, and sometimes they don't get either of those and they come right for radiation, for instance, it was prostate cancer. So it all depends on the tumor.
So 50% of the time with cancer, they see a radiation oncologist?
Correct.
At some point in their treatment, maybe not at the beginning, but at some point in their treatment, they will have 50% of the patients with cancer will get radiation.
Okay, what do you want cancer patients to know? And we're just about out of time. They're watching the show, maybe a loved one was just diagnosed? What do you want them to know
Well,
about
one thing I want them to know is that they can get university quality radiation near their home. I mean, these times of hard economic times with gas prices on, if you only have to drive 5 minutes for your treatment, why drive 45?
Okay, and people are doing that. I mean, you were at the hospital recently, and you had to send some people to other cities.
Correct. And basically, we're trying to tell people we're putting out radiation facilities in all geographic locations, both in the Coachella Valley and as well as the high desert, so that people can have, when they're not feeling their best, they can have places they can go to, receive high quality care for radiation, and in a convenient, patient-friendly atmosphere.
Okay. Is your biggest battle, by the way, getting the message out there that you're just as good, if not better, than the hospitals? And then, without saying anything negative about the hospitals, I'm curious if that's tough to overcome with the perception of the public.
Well, I think things are changing. As we have problems in this country, I really believe that the American ingenuity is not only in the technology, but also in the business models. And this business model allows us to bring that type of university level radiation to the people, and that's what's so great about 21st century.
Patients always are thinking about hospitals as their primary place to get care when they have serious illnesses, and that's sort of normal because hospitals, they're big places. Hospitals always talk about multiple programs they have, so we have to talk maybe a little bit louder or a little bit harder and more often to patients to get them to recognize the fact that what we've got is very unique. We've got experienced physicians. We've got probably the most experienced, well, not probably. We've got the most experienced physicians.
You are the most experienced
in the valley,
in the desert.
Yes.
Well, we've got
no doubt about it. Is there no question about it?
We've got the least amount of hair.
All right.
We've got the most experience. We've got the technology, and we can provide for patients what they might otherwise have to go to a university to get.
Has the technology made your jobs more rewarding than ever?
More rewarding, but not easier.
Okay.
Yeah.
What do you mean by that?
Well, I mean, now, instead of just shooting a beam this way and treating everything in the middle, now we have to outline which structures are sensitive, which structures aren't sensitive, where the cancer is. So planning now is what used to might take us 20 minutes can now take us 2 or 3 hours.
So stereotactic radiosurgery. Tomotherapy is not that, or it is that?
It can be.
Okay.
Stereotactic radiosurgery is not a machine, but it's a way of giving the radiation, where we center right on the tumor and obliterate everything in that field, but we don't go out very far from there. So all the radiation is given within 3 to 5 days. It's great, Randy, for things like brain metastasis or primary brain tumors. We also can do it in the body with respiratory gating. When the patient breathes in and out and the tumor moves, we actually turn the machine on and off as the tumor goes in. So now we're able to do stereotactic radiosurgery in the lung, in the liver, and other metastatic areas. Matter of fact, I'm doing about 20% of my cases with stereotactic radiosurgery instead of regular radiation, which can take anywhere from 2 weeks to 8 weeks to do.
What about Medi-Cal? I know one of the major hospitals in town no longer takes Medi-Cal. What about you?
We take Medi-Cal. We take all the other insurances. Medi-Cal is a program with the state of California and actually nationally as well, but it's for indigent patients that don't have health insurance, and this allows them to be treated for cancer or other diseases. And recently...
I want to make the point, though.
Okay.
If you have cancer, don't worry about your insurance coverage. Call us and make an appointment to see us.
Okay, good. That's very, very nice. What about proton therapy? And we're just about out of time. I mean, is it better than what you're doing? Is it more effective than what you're doing?
Listen, proton therapy, very interesting type of radiation. And I'll send a few patients a year for proton therapy for things that we just can't do. Very interesting for tumors of the retina of the eye, where you've got a very rare type of tumor. We might need to send for proton therapy. But I tell you, the more and more we get the higher technology out here, I have to say the less and less we end up sending for proton. It's a great therapy.
But statistically, by the way, with the cancers we're talking about, is proton therapy, where do you stack up with your technology?
Less than 1% of the patients need proton therapy. Yeah.
Okay, okay. And so you're saying areas like the eyes?
The eyes, and it used to be, we used to send for proton therapy tumors that were wrapped around the spinal cord.
But now with tomotherapy and stereotactic radiosurgery, we can do
That's
a very
very
good
interesting,
job.
because when I hear these type of ads, I'm thinking, because I always hear about this proton therapy.
Sure.
The assumption is, okay, well, that's where somebody really needs to go.
Right.
But
I think that there's pluses and minuses of protons and IMRT, and
but it's still both the same thing, a beam hitting the tumor and trying not to damage?
It's a complicated argument, but I think the point is that if you can get the radiation in safely, there is no difference between photons, what we do, and protons.
Okay.
They're both designed to deliver high doses of radiation to sensitive areas in the body, hit the tumor and miss the sensitive structures. And that's what they both do, and they do it in a very different way. The issue with protons is mostly very timely with this worldwide financial meltdown. Proton machines are incredibly expensive to put in. MD Anderson is putting in a proton therapy facility that's going to cost about $125 million. And I think it's going to be a wonderful treatment facility. The cost for proton therapy is more than conventional radiation. And when it's appropriate, that's what should be used, but not when we can use other modalities.
Okay, Dr. Masek, Dr. Greenburg, I want to thank both of you for coming on the show. Final message to somebody that has been diagnosed with cancer. They have a loved one that's been diagnosed with cancer. They haven't started treatment yet. What do you say to them?
I would say be sure that you explore all your options, go where their most experience is, and if you're ready to start your fight, give us a call.
Okay, great. Dr. Greenburg, you want to add to that?
I would agree. Things have gotten better and better from all aspects than it was when Dr. Masek and I started. The surgery's better, the medical oncology is better, and the radiation's gotten a lot better. So we're doing a lot better than we used to do, and people should not compare themselves to what their grandmothers did or grandfathers did years ago. It really is worth the fight, and things are continuing to improve.
All right. Well, thank you guys very much for coming on the show. Very interesting.
Thank you.
You've been watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. If you would like to see this interview again online or directed to a friend, you can visit our website at wellnesshour.com. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.